everybody. Welcome to Very Connected podcast. And today we're being joined by Dr. Kukreja. And he's joining us from DFW Bariatrics in Dallas. And so I'm so excited. He has his own practice. He's the go-to person at their clinic, I must say. From what I understand, he's been working with Madison, who's my daughter, and she's one of our work colleagues. And today he's going to be kind of talking about prevention and treatment of weight regain after bariatric surgery. And I'm really excited to have him. We've not had a doctor on our program before, physician, cool. A medical physician. We've had psychologists and things like that. So kind of do a little bit of your bio here. He's triple board certified in bariatric surgery and just passionate about surgery and transformation of his parents and his patients. Tell me a little bit about what triple board certified means. I'm interested.
Hi, everybody. Thanks for the opportunity to be here. I guess triple boarded starts with 5 years of general surgery, which follows 4 years of medical school. And then after that, I went into bariatrics fellowship. So at the time, there was only a general surgery board, which I took and got certified, but there was no bariatric board. And so only recently was there a board certification for bariatrics in the last 2 years. But in the interim, I did get my board certification for obesity medicine. I was one of the first 10 or 15 surgeons that got a medical board certification. And I had to apply special for that. They didn't let surgeons in initially. So that was exciting about 10 years ago. And now recently got my board certification for bariatric surgery as well. So those are the three.
So what kind of surgeries do you typically do and what kind of patients do you see in your clinic?
Yeah, so we're busy. Our practice does about 700 bariatric surgeries a year. And we do the full range, whether it's medical weight loss, non-surgical, which is defined in our hands by gastric balloons or endoscopic sleeve. And then for surgery, we do a lot of sleeve, a lot of bypass, do the switch, revision, and we take care of the complicated patients in town as well. Some of them are routine patients. Some of them are the sickest and biggest patient to date, about 780 pounds.
Really? 780 pounds. Wow. That's pretty exciting. Do you have any weight restrictions? I know the program I work for, we would only do up to a certain point. It doesn't sound like it if that's the case.
Yeah. It's funny. When I initially started the practice, my weight cutoff was actually pretty low. It was like 300 pounds. And then as I became more comfortable doing bigger patients, doing robotics, et cetera, that restriction kind of moved up and up and up. And at this point, what matters to me is certainly where the weight is placed. You can have someone who's very big, but it's not really in their belly, or how healthy they are or unhealthy they are, if they're going to tolerate a major operation or not. So I don't worry about the actual number on the scale as much as their overall picture.
Do you have certain requirements, I guess, before surgery? I guess BMI and all of that?
Yeah, we follow the newest IFSO and ASMBS guidelines. So we do some low BMI surgery, not always permissible by insurance, but we do some low BMIs down to BMI of 30. We'll operate, and on the top end, there's no high end cutoff for us. We don't have necessarily a preoperative weight loss requirement. We just want to make sure our patients are informed and doing well before we operate.
I love that.
So,
well, it sounds like there's a lot of different surgeries that you're doing. It sounds like you're doing a little bit of everything, and that's really exciting. And I love that you're actually going into the lower BMI ranges because a lot of practices
we're here to help, right? Yeah, I mean, there's a place for it. I'm not going to say that we operate on everybody whose BMI is 30, but there's certainly a place for it, especially with some of the metabolic issues that come with people getting a little bit heavier. So, yeah.
Oh, yeah. So is there anything else you want to tell us about yourself before we kind of get started with our topic? I know everybody's excited. We had I think, what was it, over 70 questions submitted. I'm like,
We had quite a few questions, and so along that vein, I'm happy to answer whatever we can. I think I'm gonna let Brenda sort of field them as they go, and if there's things that she wants to stop me with, and I can address that as we're on that topic, that's great. Or we can hit them at the end. In terms of some funny things about myself, people say they've jumped out of a perfectly good airplane. I jumped out of a perfectly good airplane that crashed on landing, so I'm glad I jumped out of that plane. That's sort of my small claim to fame, I would say.
So was that military or was that just
No,
fun,
that was just me
or?
being stupid in college. Found a discounted place to go jump out of a plane, and everybody did fine, but the plane did crash on landing. So
Well, I guess it was a good thing you weren't in there because you're here
yeah,
talking to us today, which is
exactly.
very fortunate.
So
One thing I do want to say before we get started, we have a
yeah,
lot of people that join from programs all over the US and Canada.
sure.
And for those people that are joining on the live event, this is also going to be recorded and it'll be on replay on YouTube, on our podcast station, Very Connected. But for those on the live, if you are listening, your attendance is being taken. And if your facility is one of those who ask for the attendance to be shared, and you've allowed that, you've put that in your registration form that you're okay with us sharing, we will be sharing that. And I usually share that about a week post the event and send that out. So just know, I noticed I had someone in the Q&A box already sending me a message where they're from. I do have that in the registration, so no need on this event to send that individually. And I'll let you go right
Yeah,
on in. And so again, we're going to be talking about weight kind of weight maintenance. Basically, you're going to be sharing about strategies and tools, I guess, to help us with maintaining that long-term weight loss. And I think that's why this has been one of our most popular ones. People are really interested in this subject.
yeah, absolutely. So let's get to it. Let me see if that share screen is going to work for us. Let me see. Start the slideshow, start from the start. And then here we go. We should be good. Brenda, looks good to you?
I got it. Yep.
Okay, perfect. All right. Well, great. We have over 100 people. This is going to be hopefully a lot of fun. And, I hope that you feel like I'm talking to you and with you and not at you. Our motto for our practice is live free and healthy. And that's really what this is all about. And that girl in the yellow shirt, she's my girl. She's everywhere. So if you're already bored, you can go ahead and QR code the screen and you can peruse our store. We have an online store for our practice with many ProCare products and many other products as well, where we send you discount codes on your surgery anniversary. And that is the discount code for today, 15% off over $50. And again, you can just QR code that. The website's dfwbariatricsstore.com. Easy to remember. Let's get to it. So briefly, I'm going to talk a little bit about myself. I am a private practice surgeon. I have previously been employed. I've been employed by two other practices, two other hospital systems before this, including UT Southwestern, and about 7 years ago decided to open my own shop. So I operate out of 4 hospitals, one of which I teach residents and fellows. I have a physician assistant, and I typically operate 2.5 days a week. I'm between 2/3 and 3/4 bariatrics. I still do some hernias and some gallbladders because I'm comfortable operating up in the upper abdomen. I get some gastric cancers I have to operate on too, or esophagectomies. But for the most part, I consider myself to be a tertiary care bariatric surgeon. And that means that I really, you may hear about people that don't do bypass or don't do switch. I do everything in my practice, whether it's simple or complex or something in between, revisional work. Sometimes people have complications from other surgeons and they want me to take care of it, whatever it is. So that's what I do. I'm a key opinion leader for Intuitive and on many national boards as well, and a director for a fabulous program here in Dallas as well. And I think our coordinator is also a dietitian. I told her, a little intimidating that she's watching me give this talk, is on this call. I do 99% of my cases, if not now 100%, are done by the robot. I'm happy to answer questions about what is robotic surgery. At this point, about 2,300 robotic cases behind me. So Our agenda today, I think when you're talking about weight regain, it's super important to frame your perspective, right? You have to understand where you've been, where you're going, and where you want to be. There's some evidence-based ideas around weight regain, and there's some not evidence-based ones. I, for one, am going to speak today mainly from my own experience, from having done this for 14 years with my obesity medicine background, my bariatric surgery background, and some very good friends who are dietitians. I think I know something. I don't know everything, but these are all shooting from the hips. What should we do? And hopefully inspire you to identify tangible goals. I think if you watched the other event by ProCare earlier in the week with Kate Foos, she emphasized your mantra, right? And those are tangible goals. I think that's very important to have. So let's just be honest. The surgery will do all the work for you, right? That's the assumption. You can have surgery, look back at that surgery, and you're just going to get to your destination without looking forward, right? And that's true. That's absolutely true for about 6 months, right? Everybody loses weight for the first 6 months after surgery. The question is what happens beyond that. And if you're sitting there in the ride, enjoying the ride of surgery and thinking it's going to do all the work for you, you're looking back and you're not looking forward, this is probably what's going to happen. So you have to be very intentional. And I think one of the first things is acknowledging that the surgery is just a tool is going to be super important. And so understanding your why, like why did you actually go to a doctor and say, hey, listen, I am heavy and or I am sick and I want surgery. I want you to put me to sleep and cut me to have surgery. That's to lose weight. That's a big decision you made, and you made it for a reason. Going back and remembering that reason is super important. So is it a number? Is it because you're diabetic and you didn't want to be diabetic anymore? You were in heart failure, sleep apnea. What is your why? Maybe it's that you were planning to get married the next year and you didn't like the way you were going to look in your wedding dress. That I've heard that story. Um, one of the most impressive stories that I remember was I operated on a husband and wife, and their grandchild was born in Maine, and they lived in Texas. Well, they couldn't go fly to go see their newly born grandchild because they were too heavy to get on the plane, both of them. Their daughter wouldn't bring their her grandchild home because to see her parents because her husband had died in a plane crash, and she said she was never going to get on an airplane again. So the only way for them to see the grandchild was to lose significant weight, and that's why they had bariatric surgery. So you have to figure out what is it about your life that you chose to make this decision, and did you meet that goal? And maybe there's a new why today. Maybe you've accomplished what you sought out to achieve, but now there's new things you're looking for. Maybe you've had some weight regain. There's a new goal that you have to focus on, and maintaining that motivation is certainly important. Whether you do that in the form of a picture that you keep on your mirror or a mantra you tell yourself every morning, whatever it is, you have to know your why today. And things change, right? We know this. Bariatric surgery can certainly be stressful. Is your spouse the same person? I mean, not just in name, but are they the same person that they were when you had surgery? Are they still supportive of you making the changes that you've been trying to make? Are your friends or your social circles the same? Is your family the same? Is the support that you had initially still a part of your life? These are all things that really matter as people are regaining weight and trying to look back and say, how do I get back on track? Maybe your financial situation is different and you're not able to afford the same healthy foods that you want or you need or your vitamins. So things change, or maybe you've met your goal, but you're not completely satisfied. Whatever the issue is, you have to recognize that maybe surgery was 6 months ago, maybe it was 6 years ago, maybe it was 16 years ago. Whenever it was, life only changes. A good friend of mine always reminds me that the only constant in life is change. And so you're not only will your motivation change, but all the things that are necessary to ensure your success early after surgery may change now late after surgery as well. We have to question, like, what are the medical expectations? As a physician, anyone in our practice, we can't quantify your why, right? I can only tell you what you told me. I don't sit in your shoes. I don't sit at your kitchen table. I don't go out with your friends. I don't take my patients out for dinner. So I don't know what your reason is in your heart of hearts. And so we cannot quantify the why, only you can. Now we can be, scientific about it, right? We have these great database calculators that are based on huge droves of patients, 800,000 patients or more. And these will show us, what the expected weight loss will be. And this is something, these graphs I'm showing you here are samples of what I show my patients. And these are titrated for that patient. Now, I don't remember the details of the demographic that I put in, but I can say this was a 45-year-old Hispanic female who's on insulin with a BMI of 42. What's going to happen if she gets a sleeve, a bypass, or a switch in the first year? Sleeve is red, bypass is blue, and switch is yellow there. So, I can say, hey, you're on track, or hey, you're not on track, or maybe you're ahead of the curve. But honestly, limiting the weight regain after surgery also depends on choosing the right operation up front. If, I have a patient who's 550 pounds and they want a lap band and they want to lose 300 pounds and say goodbye to diabetes, my eyebrow has to go up. I have to say, look, this is not the right option. And they may say, oh, I can diet and I can exercise. I can say, look at that. That's great. Let's look at the data. For everybody that does this, we're not going to get to our goal unless we choose the right operation. So knowing the right operation before will help to set your expectations after. Going back to the basics is super important. We talk about this all the time, but it's easy to forget about your proteins, about your vitamins, about your water, and your exercise. These are mainstays, right? And I'm probably going to commit less time to this slide than anything else, but maybe this is the most important, right? Because bariatric surgery is a tool, it's going to go with you wherever you want. It doesn't care whether it's your birthday, it's your spouse's birthday, and there's Trace Electric's cake on the table. It doesn't care that you're tired at the end of the day, you don't feel like going to the gym. It doesn't care about that. These are the constants that have to happen to ensure success, to maximize your tool in any situation. So keep the motivation ahead of you. Knowing what your reasons are will help to keep you motivated and inspired. And surrounding yourself by the right people, right? There are saboteurs everywhere. The part of the reason that we do the psyche valve before bariatric surgery is to ensure that you have the supports you need to do well after surgery. Well, no one's getting a psyche valve for you 10 years after surgery, 15 years after surgery. If you are surrounded by people who are not supportive of you, not going to give you the resources, give you the tools to be successful with your existing tool, this is just not going to work. So that might be family, that might be friends, that might be a new bariatric support group, whatever it is. These are the people around you that can help to ensure your success. And so, just like anything else, if you don't surround yourself with the right people, you're not going to be successful. And weight loss and preventing weight regain is no different. Now, there are other things that can happen, right? With these stressors that pop up in life, you may have issues around emotional eating. You may need food therapy, and those are things that are real, right? But those are not always things that you can tackle by yourself. You may have to engage a psychologist or a dietitian, or we even have a place here in Dallas that has inpatient food rehab where you are in the hospital basically for a few weeks or months at a time working on food therapy. That's necessary for some of our patients, both before and after surgery. So maybe that's part of the story as well. I think tracking food is great. One of my most successful patients, every time she put anything in her mouth, she wrote it down. She was older and she didn't believe in phones and apps and stuff like that. But even chewing gum went on her daily diary. And she would add up her calories. And if she went over her goal, she would make sure the next day, not only would she go under her goal by that much, but she would also find something else to do. She would add 10 minutes to her exercise routine, or walk an extra half mile, or aim for an extra 2,000 steps, whatever. But most of us really only eat about 10 different things. So if you can identify the 10 things that are good for you, that you enjoy, that you can fit into your routine, that will go into your pantry, agree with your family, all those things, and you can do that for just a few weeks. You don't have to track forever necessarily, but you might be surprised when you start writing things down, this sort of accountability that comes into that. Like, do I really want to write down that I just had 3 potato chips? I don't want to write that down, so I'm not going to do it. That can be really helpful for some people that need that feedback. And some of these apps, we use Bariatric in our practice. Bariatric is a great app. MyFitnessPal is a good app. These will even allow you to take pictures of what you're eating, scan barcodes, et cetera, and it'll import the data as well. So they make it as easy as possible so you actually know what it is that you're eating and what's going into it. I think there's a lot of tools out there to help keep us on track, keep us motivated. I would say that only recently did I become um, a believer in closing your circles. So set your goals with your Apple Watch or with your phone, excuse me, and make it a point to close your circles every day. My brother-in-law is on his weight loss journey. He's lost about 80 pounds. And we were recently on a family trip just about 3 weeks ago. And he spent the first 3 or 4 hours of every day closing a circle. He's like, yeah, I'm here on vacation, but I am going to close my circles and then we'll hang out. And so he wasn't hanging out at breakfast, drinking, with us, eating with us. He was closing his circles. He was doing the stairs, he was at the gym, whatever it was. But this feedback loop, and you know yourself, this feedback loop can be very helpful in that satisfaction of closing your circles by the end of the day or by 3 o'clock or whatever your goal is, can be very helpful for some people. Um, I think in our culture, we've become very sedentary. We need to find, sadly, intentional ways to be active. Um, and being active, you notice I did not put exercise up there. I know going to the gym is not for everybody. I know it's not within everybody's bandwidth or everyone's ability, but I think everyone has the opportunity to be active. And so this is different for different people. But some of the easy examples I give, just there's no need to circle for 10 minutes at the store to find the closest parking spot. You see that parking spot that's about 200 yards away, just take it and get a quick walk out of it. Not only will you save yourself time circling and waiting for parking spots, but you'll get a few extra steps in. Um, maybe that's one option. Maybe it's taking the stairs. Maybe it's just 2 flights of stairs, 3 flights of stairs, 4 flights of stairs. I'll admit, just the other day, I was walking with my medical assistant. We both walked into the building at the same time, and she's like, "Hey, come with me. I'm going to take the stairs." I was like, "Oh, great! I have to walk four flights of stairs with her because this person who's half my age wants to take stairs. Okay, let's do it." And we got to the top, and like I was a little short of breath, and she was good to go. But hey, that is what it is, and so be active. And then whenever you lose weight with bariatrics, and actually now with these fancy medications that are out there, you lose a lot of muscle. In fact, the muscle may go first. And so avoiding that muscle wasting, now muscle loss will look good on the scale, but it's not good for passive metabolism, so passive calorie burn. So you have to avoid that by maintaining your muscle because the scale doesn't tell the whole story. You can lose 100 pounds, but if 40 pounds is muscle, that may not be the best thing for your long-term health. Um, you may be familiar with the 100-day rule. They say, and now I've read studies that say as short as 21 days, as long as 300 days, whatever. But generally, most people would say that 100 days is the length of time required to internalize a new behavior and make it a habit. So try to stick for whatever your routine is going to be for 100 days. If you can do 100 days, then it may stick with you. And then I think it's okay to allow yourself a cheat day. Now, you may say that allowing yourself a cheat day conflicts with your 100-day rule, but if you are extreme about anything in life, it's probably going to lead to failure of some sort. So, this is my 8-year-old daughter. We were on a vacation last week, and yeah, she had ice cream every day on vacation. It's great. We limit her sugars otherwise, but on vacation, she had her ice cream. So, allow yourself a cheat day that gives you something to look forward to. It gives your body the space and the permission to do something that doesn't feel punitive, doesn't feel like you're being punished. And that's okay. Now, this is probably not something that you were expecting to see on this talk. A CGM is a continuous glucose monitor. I'll be honest, I didn't really have much belief in these up until recently. But one of the basic tenets of medical weight loss, of weight loss in general, is maintaining glucose homeostasis, and that is avoiding wild swings in your blood sugar. Wild swings in your blood sugar is insulin on, insulin off, insulin on, insulin off. And as your body is trying to bring your blood sugar down, it floods your blood with insulin. Now, insulin is great at bringing your blood sugar down, but how does it do that? It doesn't do a good job of depositing that sugar in your muscles or allowing the muscles to use it. It actually does a much better job of depositing that sugar into your liver and into fat for a rainy day. So the big glucose swings are actually not great. So I went out recently and got my own CGM just to kind of track my own data. And if you're a diabetic, you can probably get this prescribed for you. If you're not diabetic, you can buy them on Facebook. Actually, I saw Facebook ads for them recently as well. Um, but understanding how your blood sugar is affected with the foods that you eat every day can be really interesting, and it almost becomes like a game. So, excuse me. So this was a big sugar spike that you can see. That was my own sugar on August 7th, and I was appalled because this was something that I was enjoying every Monday morning. And what was that? That was a yogurt parfait in the doctor's lounge. So the doctor's lounge on Monday, every Monday I'm operating, and so I swing by the doctor's lounge, grab my yogurt with berries and nuts, and I down it, thinking, I'm being healthy. And that was actually my highest sugar in over a week. Was my quote healthy breakfast. And these they give you all kinds of interesting data, so you can see that you're living within your expected goals, your expected targets for sure. But having that understanding of how different foods that you eat affect your blood sugars is very important and very valuable, especially if you treat it like a little bit of a game. Like, hey, how do I enjoy this meal but not spike my blood sugars? This is actually the blood sugar range that we sometimes see after gastric bypass patients. So we see high lows, high lows. Now the A1C, the average, really isn't that high, but if you're seeing the swings, that's what we hope to avoid. And so understanding how different foods affect your swings is very important. All
Dr.
right.
Kukreja, just
Yeah.
got a quick question. There was a couple of people. Dorothy says I have a Dexcom 7 and love it. So I'm
Yeah.
assuming maybe that's one of these CGMs. And then somebody asked, is the CGM a watch type device?
No, so a CGM, there was a picture here, and I can try and show real quick. It's this little circle that you see on this gentleman's arm. That's roughly the size of a quarter, maybe a little bit bigger. Typically, it's put on the back side of the arm, and you can hide it behind a shirt. I'm not as familiar with Dexcom, but I assume it's like the others, like Freestyle, et cetera. It's a Bluetooth sensor, and it will send your blood sugar to your phone. And so some of them require that you sort of wand your phone over the device to get a real-time blood sugar. Others send your sugar to your phone in real time, and so you don't have to wand over your device to see what your blood sugar is. It just tracks it throughout the day. So they're usually about $300 if you just go out and buy one without a prescription.
So you can, Marty has their prescription only. So you can do either or. It's just if it's not covered, you just be paying out of pocket.
Correct. There are a lot of third-party companies that are coming out with these now, and interesting enough, the ones that are about $300 that I've seen will pair you up with a dietitian for a period of time, and so you'll take a picture of what you're eating. The dietitian will be able to see what you ate and what that did to your blood sugars, and they set you up with weekly meetings or whatever to review. Hey, that actually had a lot more sugar than you realized, and your blood sugar went up to 300, and here's what we could have done differently.
So tell tell these people too, what would be the reason to want to know the stabilization of your blood sugar? What would that, how does that result in
Yeah.
weight loss,
So
weight gain?
insulin is generally your friend because it brings down blood sugar. It's your enemy because it brings down blood sugar by making the blood sugar go into your liver and into fat. If your liver is already full of sugar, which most of ours is, then it just makes it go into fat. In fact, if you talk to diabetics that are diagnosed with diabetes and started on insulin, most of those people who are given insulin injections gain 50 or 60 pounds in their first year because now they're getting all this insulin in their body. So the goal is to, although insulin does a good job of lowering your blood sugars, the goal is generally to minimize the amount of insulin your body requires. So insulin goes up when your blood sugars go up in an attempt to bring your blood sugars down. So if you're able to minimize the blood sugar spike, then your body needs less insulin. So less of that sugar has to be deposited into fat or into your liver. So the whole idea is really to maintain your sugar as at flat a curve as possible. Now, you're never going to get it completely flat, right? Everything that you eat has some sugar. I mean, you eat a carrot, it has sugar. You eat a red pepper, it has sugar. But ideally, we want to maintain as flat a curve as possible. You want to avoid the big roller coaster spikes. This is what you want to
Gotcha.
avoid.
Okay.
Yeah. Okay. Does that make sense?
Yeah, I think
All
so.
right, let me get through these slides. Okay, so we're kind of getting here to the end, but knowing when you need to apply the brakes is important. If you're trying to stop the train from weight regain, just remember most surgeons do surgery, and that maybe sounds rude or offensive, but that's the way we are. We love surgery, and we are good at what we are good at. So, I think that most of us are pretty good at surgery. We may be less good at taking care of some of the metabolic issues or weight regain. So, recognizing that is important. It's also important to follow up with your team. Is your weight regain related to a GG fistula, a problem anatomically? But really, the accountability of seeing your surgeon is important. I always wonder when my patients don't follow up, is it because they're not doing well? Um, I remember one patient of mine who did great, and I don't remember his numbers, but he lost a lot of weight. He was initially wheelchair bound and ended up as a private detective, and so obviously he was no longer in a wheelchair, and he was doing great. And he lost a lot of weight. His pictures were up in my waiting room, and I didn't see him for like 4 years. And um, I don't check my clinic schedule every day. One day he was on my clinic schedule and he walked in tears. And I was like, oh my gosh, what's going on? He's like, look, I had those pictures in your waiting room, and that just is a reminder of where I was. And now look at me, I'm back here for a revision. And so the people that sometimes don't follow up because they're embarrassed or they're ashamed or they feel like they may have disappointed their team, their surgeon. And that's not the case. We're not here to judge you. We're here to support you and put you in touch with the resources that you may need to be successful and maintain your success. So I think follow-up is undervalued. The way our healthcare system is set up does not incentivize patients to follow up, both from the physician side as well as the patient side, right? I mean, if I have patients that are doing super well, they don't want to pay their copay for a high five and a hug. They want to feel like I did something for them. But it's really important for both sides, both the patient and the physician team, to have that follow up to know that everything is going well. Now, the adjuncts that are out there may be related to physicians that are in obesity medicine space, maybe medical weight loss, maybe surgeons that are doing obesity medicine, maybe involving psychologists, maybe involving lab work. There may be a place for medications in our practice when we have patients that are not following those curves that we showed you initially, and their weight loss is less than maybe is expected. Then we talked about, hey, I know you're only 4 months out of a sleep, but let's talk about some medications. Maybe there's a role to start working with the dietitian again, or keep working, or a different dietitian. Have they passed through menopause, which slows metabolism by 40% for most people? Have you gone through all of these things? Have you checked your metabolic rate with a resting metabolic rate machine? We have the ability to actually check the metabolism, and the harsh reality of the way our body works is, as you gain weight, your metabolism doesn't go faster, but as you lose weight, it goes slower. So people who lose weight actually have a much slower metabolism than the person who never lost weight but has always weighed and been that same size. So they're going to have different goals, right? Their metabolism may be 30% slower than their twin sibling. So those are all adjuncts that have to be addressed with weight regain. So obesity is a disease. If you look at Hippocrates, who's considered the father of medicine, and this is maybe still true a little bit today, but this is how he viewed obesity care. Now, I think this highlights the stigmas that come with obesity, but back then, Hippocrates said, "Don't eat while exercising." So I think he was poking fun there, unfortunately. So don't eat before you've cooled down after exercising. He's just telling you, don't eat. Drink warm diluted wine before you exercise. So you better go exercise and be drunk while doing it. Stop eating so much. Be dirty. Eat hefty foods or whatever it is. And then sleep on a hard bed. This is, I don't know. But this is what Hippocrates said is the treatment for weight regain after bariatric surgery. And I think we've evolved a little bit. Some of our things have become a little bit more compassionate, but regardless, I think obesity is a chronic progressive disease. So understanding that it's progressive, even without bariatric surgery, chances are you're going to weigh differently when you're 80 versus 20 or 60 versus 30 years of age. It's a progressive disease. And there's no cure. We've never sold, or at least we should have never sold, bariatric surgery or any weight loss intervention as a cure for obesity. It's a disease. It has to be treated. So with that, I'll remind you, here's our ProCare Rocks coupon on our store for your vitamins. We have bundles for our patients on liquid diets, on soft foods, or on solid diets that have a variety of good foods to help people along their journeys. So check it out. There's your QR code if you want to scan it. And you can follow us on social media. We're at DFW Bariatrics all over the place: Facebook, YouTube, Instagram, and TikTok. So that's what I got.
We had a lot of questions during this too. So
Yeah.
I feel like, in summary, what I got out of that is, stick to, go back and really look at, first of all, picking the right surgery is detrimental. And I think after picking surgery, talking to your providers, making sure that whatever you are doing is the right individual choice, looking at your why and what motivates you, because that's so important. Looking at the basics, your protein, your water, your activity, your mental mindset. I mean, obviously
Yeah.
that has a big part. And surgery is not just a be all do all. It's a lot of different things. Is there anything that you wanted to add to that in summary before we start answering some questions? I don't know if can you hear me?
Sorry, it cut out for some reason. I could not hear
Oh,
you there for
sorry
the
about
last.
that.
No, I
Um,
think it was me and my AirPods. I apologize.
yeah, I was just going to see if there's anything you wanted to add to that before we kind of start doing some Q&A.
No, I would love to add to that, but I missed the 30 seconds of it, so I wouldn't know what to add to, but I'm sure it was great.
I basically was just kind of like thinking back your PowerPoint and all the good points that you made about, basically talking to your providers, and I agree, a lot of times people think they're scared to go back especially after that first year, sometimes if they have had any weight regain, but these are your people, like you've got their back. And it's much more than sometimes they know where to start. Like sometimes we think, obviously if you're doing all the basics and you're doing all the right things, there's other things to look at and make sure and find the support you need, whether it's in your friends and your family, but also your providers, and the people that care about you. Um,
Absolutely.
so at that, we have a lot of people just saying thank you, thank you, thank
Yeah,
you.
of course.
Um,
It's fun.
everybody, I'm just going back. Michelle, hello. I'm gonna go kind of back. I kind of was writing down times when people ask questions. We actually have a Q&A feature, guys. We're gonna try to get to most of those, as many of those as we can. I'm just gonna go back through the chat because there was about 4 questions and I
Okay.
wrote down the time. So I'm gonna look at those here real quick and we'll get to as many as we can. Dennis says, it's either Dennis or Denise, I can't see the full name. Wondering if we are at a comfortable weight, how many carbs per day can we reasonably have? Dietitians say we need 100. And then the question is really, or is there another number?
Yeah, I mean, I don't know the number is going to be the same for everybody. I think it depends on your blood sugar tolerance. I mean, you may have somebody that can metabolize through 100 carbs a day, but they're exercising a ton. You may have somebody that does it really well and their blood sugar never spikes. Um, it all depends on the patient, and so I don't like, blanket statements of you need 60 grams of protein, 60 ounces. Yeah, there's some general rules there, but I'm not going to say that every patient needs X number of carbs. I think it depends on the situation. I know most dietitians don't necessarily believe in ketosis. Um, our coordinator, who's also a dietitian, does actually emphasize carbs and carbs being a good thing. So I think we definitely need them. I can't give you a number to shoot for without knowing your whole situation. And even then, I would still defer to a dietitian.
Yeah, and I say too, like if you're writing down everything you're eating and you're not making progress, talking to a dietitian and seeing if there needs to be a change. If you're doing well, then you're doing well. So,
Yeah,
Mary says, have you ever done bariatric surgery on someone with polycystic kidney disease with enlarged kidneys?
we have. In fact, we do a lot of people who no longer have kidneys so they can get transplanted. They may be too heavy for kidney transplant. So, yeah, polycystic kidneys alone are not a problem.
I love that too. I mean, people getting we had patients in the program that I worked with that were actually needing to lose weight to have a kidney transplant,
Mhm.
So
Yeah, we have quite a few of those.
yeah. Okay. I believe it's Lauren. It only shows me parts of their names. Can you give a general range ratio percentage of how often one should work out, be active a week to to a week to one, it says maintain weight and two, lose weight.
So, okay, so there are a couple of components to that question, right? I don't think anybody who's not exercising if I said 6 hours a week, should go and suddenly try to do 6 hours a week tomorrow. Okay. I think these have to be small goals. Maybe the initial start is 20 minutes at a time, 2 days a week. And then maybe it's going to be 20 minutes at a time, 3 days a week. And then maybe you're like, I can't do 4 days a week. So now it's 21 minutes or 22 minutes, 25 minutes. And maybe you are going to be doing, um, you know, 2 miles on the treadmill or 2 miles outside, or maybe it's going to be 3.5 miles an hour. And now the next week is 3.6 miles an hour, or it's 2.1 miles. So you have to set miniature, attainable, reasonable goals first. If you're talking about cardiovascular health, most of the guidelines are 150 minutes of intense exercise weekly to maintain cardiovascular health. There was recently something that came out that said that 150 minutes, it was previously um, meant to be done over a few days. They said you can still get the same cardiovascular benefit if you do it all on Saturday. Great. I don't know. but 150 minutes a week is a recommendation. Generally, in my experience, exercise doesn't result in much weight loss in and of itself unless you're inducing a calorie deficit. Now, most people, when they're exercising, they burn however many calories on the stair step or whatever, they're burning calories. And they get home and they want to eat, right? Because your body's designed to eat the calories that you just burned off. You're hungry. So that's completely normal. So exercise may be a part of weight maintenance once you find that equilibrium, but to really have weight loss, you have to do enough exercise to fall into a calorie deficit. And you don't necessarily know what your resting metabolic rate is unless it's measured. You can't assume, I mean, not everybody, despite what the ADA says, needs 2,000 calories a day. Um, that number is different. I measure people's metabolism. Interestingly, my kidney failure patients tend to have the worst metabolism, and I've seen resting metabolic rates as low as 700 calories a day. So anything above that, they're going to gain weight. So without knowing your starting metabolism, it's difficult to prescribe an exercise regimen that's going to allow you to lose weight. But either way, you have to come under your resting metabolic rate to lose weight with exercise.
Do you have a way at your office, or could you recommend a way for people to know what their basal metabolic rate is?
Yeah, so we use a calorimeter in the office, and that's indirect calorimetry. And so what it does is that is a tube that you breathe into, and we seal off your nose. And basically, it's measuring carbon dioxide. If you know how your body processes foods, it basically converts them all to carbon dioxide in the end. You breathe it all off. So by breathing off all this carbon dioxide, it measures how much carbon dioxide you're breathing off. So just like a car, if you could measure how much exhaust it's putting out, then you know how high the RPMs are. It's the same idea. So I can have you breathe in this machine for about 15 minutes, measure the amount of carbon dioxide that comes out. And by that, I know how many calories you burned in that 15 minutes. Then that can be extracted from 15 minutes. Well, how many would you have burned in 1 hour and then 24 hours? So yes, we can do that. There are equations out there like the Harris-Benedict equation or whatever. You can find that online where you plug in your height, your weight, your age, and it'll tell you what your metabolism should be. But that has absolutely nothing to do with your body. So what we see is that people, once they've lost weight, whether they lose it on their own, medication, surgery, that number actually falls far below the estimates from Harris-Benedict equations.
Oh, that's so interesting. Yeah. I mean, it's good to know. Do you measure your patients before and after surgery?
We do measure it before surgery. We measure it after surgery. People are not are falling off the wagon if they're not losing what we expect them to, or having weight regain. Yeah.
So interesting. Okay, we have, let's see. Dorothy says, I had major reconstructive foot surgery in April, and I'm not full weight bearing. So what can I do to help me lose weight while I'm wait to get full weight bearing? I'm guessing she had weight loss surgery, but I don't know for sure.
Probably the first two things that come to mind are resistance bands and swimming. That's probably where I would go first.
Yeah. And I'm wondering too if she had any kind of physical therapy or anything, because sometimes those things
Yeah.
can be really helpful. They have specific types of activities. Okay, I'm going down here and I'm going to go on to the Q&A. There's 13, so we'll do a few of these.
Okay.
Um, Someone asked, what are foods you would absolutely stay away from months after surgery, specifically with a DS?
Um, yeah. So DS is a funny operation in the sense that we do a lot of it. But the surgeons make the channels very variable lengths. I have some good friends who make it 75 centimeters. I have some people that make it 300 centimeters, and that's going to dictate your weight loss, your fat malabsorption, your vitamin absorption, all of those things. Now, the other variable there is the ileum, which is the portion of the intestine that's used for a DS, is very stretchy. So what I call 100 centimeters, someone else might call 120, 130, 140. I don't know because it stretches so easily. But generally, after a DS, you should have been counseled to definitely avoid fattier foods. And then the high carb foods can also cause issues around diarrhea. Now, people will say that's dumping syndrome. It is not the traditional definition, medical definition of dumping, but it certainly feels like it for a lot of those people. So, avoiding fattier foods and high sugar foods, and then focusing on your protein.
Good suggestions. It looks like I want to add, Christy Hale says our office uses the body scale, which gives us their metabolic rate as well. So that's good to know.
So the body scale is an impedance scale, and it's not actually measuring your metabolic rate. It's estimating your based on your body composition, but it's not a measurement. So it's like looking at a building and saying what that building weighs. You don't know until you actually weigh it.
Gotcha. Okay. Another question. What do you think about intermittent fasting? I always feel like there's always a high question. A lot of people ask about that.
Yeah, so intermittent fasting actually has been shown, calorie restriction in general has been shown to improve overall health and longevity. Intermittent fasting is an Eastern idea and tends to have better control of blood sugars than having 3 meals a day. I'm not sure where the idea of 3 meals a day came from, but intermittent fasting definitely works for some people.
Hey, next question. I am 2 years post VSG and started experiencing acid reflux about 12 months post surgery. And over the last year, my reflux has continued to get worse. The only thing that helps is consuming food to help soak up the acid every couple hours, particularly foods like bread, crackers, etc. I've maintained my weight loss, plus or minus 5 pounds, but I'm growing concerned that this is going to lead to regain eventually. I no longer live near my bariatric surgeon. Do you recommend seeing a new bariatric doctor for this issue or a traditional gastro doctor?
Yeah, that question has a lot to unpack there for sure. Sleeves may worsen reflux in at least one third of patients. An additional one third actually have worsened reflux and don't know it. And then a few years after surgery, we don't know who's having reflux anymore because follow-up is so poor. But I do question, new onset reflux. It can be a lot of things. It can be a dysmotility problem. It can be a new or a return of a hiatal hernia. It can be a stricture of the sleeve. And what patients interpret as reflux is not always reflux. It can be other things. So that all has to be teased out for sure. Um, and so, yeah, soaking up the acid with crackers or bread or whatever may make you feel better from the burning that you're having, and the weight regain may come. But what you don't know is the damage that's actually being imposed on the esophagus from the reflux that you're feeling. And so, to answer your question, if you wanted to get this addressed, and I think you should, um, you're going to be involving both a bariatric surgeon likely as well as a gastro doctor, gastroenterologist.
Okay. Michelle says, I've lost 86 pounds doing keto and intermittent fasting, been stalled and slowly gaining 25 pounds eating the same way.
Yeah, so all the same tips that we went through apply. Intermittent fasting or keto or both. I think we have to look at the whole picture and start from zero. So, what is your metabolism? What is the goal? Is your weight loss already exceeded where we would normally expect with that procedure? All of those things matter. I mean, could it be your thyroid? Could it be other hormones? All these things are in there.
It's so individualized. That's hard because like when we have a question like yours, Michelle, we want to try to answer it, but there's so many variables, for each person,
Yeah.
it's so individualized, age, physical activity.
Yeah,
There's
there's
this
a lot there.
type of surgery. Yeah. Okay, Teresa says, how often? I would say too, Michelle, if you feel like that, I'm not sure how far post-op you are, but if you would want to talk to your surgeon or dietitian, maybe they could help you with maybe looking at some of the other things that we did talk about. Um, Teresa says, how often should we have a cheat day? I think you talked about this actually, so
Yeah, I mean, I think what works for me may not work for you. I got a chiding text from a good friend of mine who's watching this, and she said it should be a cheat meal, not a cheat day. Um, so I think what works for you, whether it's what works with your family and you, what works with you, whether it's weekly, every other week, once a month. What you can do that is sustainable and makes you happy is important because ultimately your happiness is also important, but you have to keep your eye on the goal.
yeah, because really, I mean, it depends on if that cheat meal or cheat day becomes more and more, and it becomes more the
Right.
normal than
We
not
are
the
calling
normal.
it a cheat, right? We're calling it a cheat. So you got to
The
figure out how
normal.
often it's okay. Yeah. Yeah.
Okay, Nancy says, does this sense through your skin, or does this sense through your skin, or is there a break in the skin? Pin needle. Not really understanding
It's a
that much.
little, yeah. That little disc, that you saw has a needle that goes into the skin. Yes, there is a needle that lives in the skin for 2 weeks while the battery is running on the sensor.
I wondered that too, actually. I was glad that question came up. Okay, does your RMR still drop with gastric surgery?
Yes, your RMR drops regardless of how you lose weight.
Okay. Ashley says, how do you normally measure the RMR? Indirect color telemetry, I believe is how I'm saying should say
Yeah,
it, or different
indirect
methods.
calorimetry, yes. Yeah,
Okay.
indirect
And
calorimetry.
do patients normally have this done as a follow-up or just in the setting of weight regain?
Yeah, so we don't routinely do it on everybody unless they are having some weight regain or inadequate weight loss. We do make it available to our patients if they want it.
Okay. CGM sensing. How is this through the skin? I think you might have just said that.
Yeah.
Okay. And then we have somebody ask, I had a rebound weight gain of about 50 pounds after reaching the lowest weight. My surgeon warned me that this may happen. Does this count as regain or is this normal?
The average person after gastric bypass surgery, and I'm not going to say sleeve because I don't know the data on sleeve if there is, but the average person who loses 100 pounds after a bypass will regain 15 pounds. So I'm not going to say it's normal. I'm not going to say it's regain. Maybe the right word is expected. I don't know, but 15 pounds or 15% is the average.
Okay. Good answer. Nancy says, what is food therapy?
Um, so food therapy, like we have a place here in Dallas called the Eating Recovery Center. Eating Recovery Center does just that. So you may go there and meet with a dietitian, and they may say that you don't need to go to them. They may say that we think you have anorexia or bulimia or some sort of eating disorder, food fear, food aversion, whatever. And they may say you need weekly therapy. You need to meet with us once a week, just like you would meet with a psychologist or psychiatrist. They may say that this is like a drug addiction, and you need to be actually hospitalized for a few weeks or months. That happens too. I've seen that happen to where people have to be removed from their native environments, removed from their family or their social systems, and put into a completely controlled situation to regain their pointers and their bearings.
So does insurance cover these? Typically these,
It's in some situations, they have covered, not always, but in some situations, yes.
do you have pointers on how to reduce hair loss after surgery?
So hair loss happens no matter how you lose weight. Diet and exercise, GLP-1, surgery, hair loss happens. Now, your body doesn't view hair as important. As sad as it is to say, I like my hair, what's left of it. Um, but hair is not important to our bodies. Neither is skin, neither are nails. So as you're losing weight, your body sort of freaks out and says, "Oh my gosh, I don't know that I have the nutrition that I need to keep going. So let's prioritize what matters. What matters is not my hair, not my skin, not my nails. What matters is my brain, my heart, my lungs, my kidneys, all those things. So let's redirect all the nutrition there and direct it away from hair, skin, and nails." So, we tell our patients that the basic principles around hair loss is you will lose hair. You will lose it typically the most between months 4 and 7. But if you don't start emphasizing hair loss until months 4, you will still lose that hair because you have to build up the reserves. So biotin is very important, iron, protein, and then maybe some collagen as well. I don't know. There's data on both sides for collagen, but those are the principles. So protein, iron, biotin, collagen.
And so those some of those things are you can use supplementation for the
Mhm.
biotin and the collagen and the protein if you need that too.
Yeah.
So, okay, Vanessa says, what is a good weight loss rate per week for someone who is 2 months post-sleeve?
It's impossible to know. But that is why we use the graphs and the risk calculators for our patients, because my patient will ask me the same question. Hey, I'm 2 months post-op. Am I doing as expected, better, worse? And if I said 15 pounds, that may be really good if you started off at a BMI of 28 or 30. That may not be good if you start off at 550 pounds and you're a man, right? So both of those patients are going to have different 2 month weight loss results. So you have to, at least in our hands, what we do is we plug everybody in and we can say, okay, the average person in your situation would have lost 27 pounds by month 2. You've lost 29, so you're doing better than average. So that's a
Yeah.
publicly available website. If you just plug in the misclick calculator, you can plug in your own demographics. In fact, I think I can probably share it here. Try and be fancy. There you go. So that's there now on your message, and you can on your Q&A, and you can go there and plug your own data in and find out how much you should have lost in that time period.
I'm wondering if maybe when you put it on there, if it went to everyone, like under the
I,
little,
I did it under a Q&A. I can type it in the chat.
oh, it might, okay. I was gonna
There.
say I
Now
can
it's a
copy it there. Oh, thank
yeah,
you. Thank you so much.
yeah.
And I know we're kind of over on time here a little bit. We'll take one more question. I know we got a ton of them. I'm just gonna randomly pick one. Someone asked, I'm 4 years post-op VSG. I've gained 10 pounds and worried. Should I do the post-op diet to reset and get back on track? So 4 years and gain 10.
Yeah, I don't think the post-op diet in of itself is what's going to help you lose weight. I think what's going to help you get back on track is resetting your whole parameters, right? Why did you have surgery in the first place? What's your new goal? Maybe your goal is to get back to that smallest weight. Maybe your goal is still ahead of you. Maybe it's to get your diabetes under still better control, whatever. But using all those principles that we just went through is going to be important to get back on track. So yeah, maybe starting your post-op diet is important, right? But what you do on that post-op diet doesn't matter if it's not sustainable. So figuring out what you can do that's sustainable is going to be key.
Okay, we'll press done. Well, I know there's lots more. Maybe we'll have to have you back at some point because people love this, and we really appreciate your time and energy. And coming from a position and the knowledge standpoint, it's really helpful because a lot of people do have questions, and sometimes they don't always feel. I think this is a safe place to ask
Yeah.
questions. Sometimes in a support forum. So we truly appreciate you being here. And guys,
Thank you for having me.
check
This is
out,
fun.
yeah. Um check out, I'm gonna kind of go real quick here. I'm gonna share my screen and I am actually gonna go to the place here. I'm sorry, I pulled up my notes instead of your site here. But this is Dr. Kukreja's website and his store. Like his regular website has this, and then you can actually just click on to get to his store, and has all
There's
kinds
my
of good
girl. Same
resources.
girl, my girl. She's there.
Same one on your PowerPoint.
Yeah, there you
Do you
go.
know,
She's
actually know
everywhere.
this girl, or is this just a person that you
No,
chose?
no comment.
Well, thank you so much, and truly a pleasure. And I
Thank
think
you.
everybody else is thanking you too. Everybody have a great evening and right, take care. Thank you so much again. Bye-bye, everybody.